Welcome to Wisconsin's Youth Health Transition Initiative Learning Community. Dr. Krisjon Olson is Assistant Professor in the Department of Pediatrics, Division of Pediatric Cardiology, School of Medicine and Public Health. She's also the Building Interdisciplinary Research Careers in Women's Health Scholar at the University of Wisconsin-Madison. Olson's research aims to address the gender health gap and improve outcomes in congenital heart disease. She conducts ongoing fieldwork with children and families facing difficult treatment decisions in pediatric intensive care and beyond. Olson works with survivors, community organizations, and healthcare providers to address outcomes inequities. She aims to promote longevity of survivors and facilitate their transition into adulthood. Dr. Olson and her team will present on disparities in adolescence with congenital heart disease and disabilities, feasibility and acceptability of using transition readiness assessments with this population, and their exciting upcoming HeartWise project. Welcome, Dr. Olson and team. We are so excited to have you here today.
Thank you so much for that introduction and also for the invitation to speak today. We've really benefited from our partnership with you over the years in both getting this work started and then continuing to do some of our early research. And we're really partnering with people who have congenital heart disease to better understand how we can improve healthcare transition. Um, and that's what I'm going to speak to you about today. Here are some of the objectives of the presentation to describe some of the disparities for people who are 12 to 26 with congenital heart disease that we found here in Wisconsin, to learn about the transition readiness assessment that we've been piloting and the adaptations that we've made to that transition readiness assessment, to identify elements of accessible healthcare transition, so accessible to people with disabilities, and then also describe our upcoming HeartWise project that looks more carefully at Wisconsin's Medicaid enrollment patterns, especially as it pertains to people with congenital heart disease. So, sorry, not used to the, oh, not used to the buttons. So what is congenital heart disease? It's a condition affecting 1 in 100 people that accounts for nearly 10% of healthcare costs in the United States. And really, part of what I wanted to show with this depiction was the traditional approach that's used for understanding congenital heart disease, which is this kind of phased developmental approach to understanding congenital heart disease, which of course impacts people when they're first born and then all the way into adulthood. Um, and our team really wanted to ask questions to understand how affected individuals experience the transition from pediatric to adult healthcare. And one of the things that we know is that there's been kind of a tidal shift in survival for people with congenital heart disease. And in the next slide, I'll show some of that. But we know that now, today, 97 of the people that are born with congenital heart disease will survive into adulthood. So, like I said, this is something that we've known for quite a while, that the survival curve, which you can see depicted in this article from Jack on the left, has changed. So 50 years ago, it would have been relatively uncommon for someone with congenital heart disease to survive into adulthood. And that has really shifted both because of changes to and improvements to surgical procedures, intensive care, and the support that is provided to young people. And so we see this shifting survival curve. At the same time, we've long recognized that people with congenital heart disease also experience disabilities. So back in 2006, Gil Wernovsky published an article in Cardiology of the Young that started to characterize the relationship between cardiac defects and disability. And this is how it was depicted in that early article. Hi, I'm Krisjon Olson. I'm a scientist and a person with a disability. Today, I'm going to be talking to you about our experience working with patients like Maria who have congenital heart disease. Um, and I share that experience of disability and living into adulthood with a disability. I have cerebral palsy, and I lead a team of scientists, doctors, and community advocates working to understand why patients like Maria drop out of care and what we can do to address it with equity-driven solutions. Maria was born with a congenital heart defect that affected the pumping chamber of her heart, um, and endured 3 surgeries and 10 months in the hospital to repair that single-chambered heart. And while 97% of these patients now reach adulthood, half, women and people with disabilities in particular, drop out of care, which really deepens health disparities. And so one of the early things that we really set out to understand is, how do families and patients make medical care work? So I'll tell you a bit about the initial work that we did that led us to start asking these questions, and a little bit about the story of Maria, um, which is a composite uh, name assigned to the case to protect the identity of our participants. So when we first started working together, we were really looking at what were the factors driving and impacting healthcare transition in our clinical setting. And so here's a key driver diagram from that early quality improvement work where we identified different factors that were really impacting patients. And in that first study of 150 patients, we found disparities for adolescents with congenital heart disease and disabilities. I'll give you a look at what that looked like. And you can see we were using a very traditional transition readiness assessment, looking at confidence in taking care of heart health, whether they need lifelong heart care from a congenital heart disease specialist, knowing what to do in a medical emergency, having a paper or electronic file for their medical information, and carrying that information with them. And that's really where we initially identified those disparities in knowledge of their health and healthcare usage. And so part of the question was, why? I think part of what we found is that the prior research doesn't really reflect the population today. We know that the population has changed. People are much more likely to survive, and some of the broad survey-based research suggests that 50 to 75% of people with congenital heart disease share the experience of disability, though they're diverse in many other ways. And so we really wanted to understand why, up to 63% of patients are lost to care between the ages of 18 and 21. And we found that um, for, like Maria, many of our patients have disabilities, and really it's an emerging public health issue that forces us to address disability, ableism, and questions of access. And so what is the problem with some of the existing models for healthcare transition. Many of the clinical tools and interventions have been designed for people without disabilities and take this life stage approach, right? That does not necessarily account for a patient's social support needs. So we wanted to try to understand this better. And to do this, we really took a look at our own database, which includes 796 patients with congenital heart disease cared for here in Wisconsin. And here you can see some of the demographic information about those patients. So first, we wanted to start to look at disability, what that disability looked like, and then we did a stratified sample. So all that that means is that we really wanted to get a representative sample of the different kinds of experiences that patients may have. And so we were really looking, as you can see in the green at the top, at learning differences, communication differences, mobility differences. We also wanted to stratify for mental health concerns, and I think it's worth noting, and we can discuss toward the end, that we weren't able to stratify for mental health concerns because almost all of our patients had mental health concerns. So it was something that was included but not stratified for. And then when you look at social support and then other transitions that uh, patients had experienced over the course of their medical care, I think this was something that very important that we learned from our initial review, right? Is that this healthcare transition is not the first transition that these young people are undergoing. Many have had profound shifts in their social support, um, in their school setting, um, and also, as you can see at the bottom, changes to their medical home, their insurance, or the people who provide them healthcare. Um, in particular, and this is what led to our upcoming research, diverse families tell us they enroll in community programs and public insurance early in their child's diagnosis, but lose access to it later in life. Many are unaware of the available benefits in the community. And so that really led us to ask questions about what the barriers and facilitators uh, are for patients and families. So we did this formative research, which included interviews inclusive of those with disabilities and community advocates and also healthcare providers, that really became the basis for our understanding of the transition for young people with congenital heart disease. And it was in this research that we discovered that up to 70% of families had experienced what we call insurance intermittency. What that means is that, you know, they'd had a change in their insurance or periods without insurance coverage, and particularly for older young people, once they reach their 20s, that became a significant barrier in accessing care as an adult. Um, at the same time, we found that while patients with disabilities typically might qualify for Medicaid, many lose access as they transition to adulthood, are unaware of available benefits, and there's rarely education from providers on disability-related insurance options, services, and supports. And this really compounds disparities. So I'll share a little bit of what we learned from this early work. Um, so here you see this figure, which what we really wanted to depict is the way in which, as someone gets older, they have narrowing support in the transition period. That is to say, exactly as they are reaching this time of change, they may have less support than they've previously had moving into adulthood. And especially for our young people with disabilities, there's actually a disability, what I call a disability health paradox, where they may have more access to community resources, school resources, advocacy resources, vocational resources, and yet they still experience greater disparities in their readiness to transition to adult care. Part of this, we began to think, was due to this gendered care network. So when we asked young people, who leads your care team, 97% said their mother, right? And this support really narrows sometimes to be exclusive to the mother over the time as they get older. So if we think about a patient like Maria, her mother, when she was an infant, learned to perform tube feedings, provide physical and occupational therapy, monitor her oxygen saturations, and her parents were making decisions on her behalf, right? Sometimes this is called proxy or shared decision making, with cardiologists at 2 different medical centers, surgeons, intensive care doctors. As Maria got older, her appointments that were once attended by multiple family members increasingly included only her mother. Her mother was now a skilled caregiver and expert medical historian. Her father, unemployed during her earliest hospitalization, was now working 2 jobs. Right. And so you see this narrowing of the support network over the transition period. So we decided to look at patients' medical records to see, okay, patients are reporting that, their mother's leading the care team, but when they actually come into the hospital, who is with them in those encounters? And you can see that it is true about half the time someone who's identified as a mother in the electronic health record is present, but there are actually a lot more people involved. Right. So you see in orange the non-mother nuclear family, in the kind of mustard, the multi-nuclear family, and then extended family. And so what may actually be happening is an over-reliance on mothers, but especially in relationship to direct support needs and enrollment in public benefits. So let's see. Um, so going back to the case of Maria, as she got older, her needs became more complex. Her vocal cord was impacted during a follow-up surgery, and she began to have difficulty speaking, and was further relying on her mother when she came to appointments, was waiting to be seen in developmental clinic and qualify for extra help at school. During high school, Maria's father was deported, and her mother is now providing for the family with 3 part-time jobs. She finished high school and decided to work as a nanny, a job that she really loved. But at her first cardiology visit in adult clinic, she received a bill for $3,000 and quickly realized she would need employment with better insurance coverage. At the same time, her cardiologist recommended a new device be placed to help her heart function. Fearing medical debt and overwhelmed by the choice of devices, she dropped out of care for 2 years. And so part of what we wanted to depict from our findings in this figure was really how tracking impacts patients in particular. One of the things that we saw is that young people are often tracked both by hospitals, schools, and social services. And what does that look like? In the case of Maria, right, she was not, she needed a lot of support early on in her first year of life, received birth to 3 services, but then did not need additional support when she first went to school. So she gets tracked right into the category of a child who does not have a disability, but then her needs increase over time, and sometimes that goes unrecognized. Right. And so I think in order to effectively support patients like Maria, we really need to address these hospital, school, and insurance silos. So what did we do? This led us to create some new tools. So initially we were using the transition readiness assessment from Got Transition, which measures confidence and knowledge, and is a 21-item tool. And now we're using this adapted transition readiness assessment. In our working with young people, we really recognize the need to not only measure confidence and knowledge, but also the patterns and intensity of support needed to complete those transition tasks. And so now we're using a 24-item tool. It has adult and pediatric scales. And we've been piloting a risk stratification score. It allows young people and their healthcare providers to prioritize areas of interest over time. It's digital, it's on an iPad, and then uses plain language and graphics selected by folks from our clinic and includes local resources. And I'm sure Michaela or Humail would be happy to share those resources with this group if that's of interest. And I feel like we learn about new resources all the time from the people that we work with. Our youth advisory committee also talked quite a bit, especially the patients who had made the transition to adult care, about wanting to ask questions during their cardiology visit, but not being sure what questions to ask. So we worked together with the young people that participated in our research to create this question prompt list. And we've also been piloting the use of the question prompt list in clinic. So this is what that question prompt list looks like. And really the goal is to meet support needs, human or otherwise, as we see here. And we really learned from young people like Maria that we needed to do different research to understand why so many people drop out of care after life-saving treatments. So while some of our current work centers young people with disabilities, we go far beyond that. Our work now includes medical assistants, schedulers, sonographers, doctors, nurses, and community advocates, some of whom have CHD. In the case of Maria, she went on to needing a ventricular assist device. And when we talked, she described paralyzing uncertainty, having no questions during her emergency admission, and then profound questions after the admission. And this was, and I think that the experience of the family really watching her from infancy into adulthood was marked by this trajectory. And I think it impacts all facets of young people's lives. This is how a young patient introduced himself to us at the beginning of an interview. And if we look back at the description of our participants, you know, about 10% of the time, young people identify as having a disability, and that disability is not documented in the medical record. So I think learning from people how they identify is also important. And thinking about what the support they need and what that looks like also matters a great deal. And so I think, you know, often this description of paralyzing uncertainty is one that is described by patients who have more complex trajectories. And I think that, you know, every admission has, you know, hopefully has a last day. But we need to think about what that means in terms of the register of people's experience, or the system that is often quite burdensome. And so really the goal of our group is to study access and rethink what transition could look like, not only for people with congenital heart disease, but all people with disabilities. And what this really has required is interdisciplinary work between, ourselves. We've incorporated Jessica, who I believe is here, who is a health economist here at UW, Brianna Swanson, who is a nurse practitioner in the adult congenital heart disease clinic, and others across the healthcare setting to really rethink, both biologic and ethnographic data, and really how people experience this transition over time. And I think we really need to account for the life course of young people whose lives are unfolding before us, and understand survivorship for people like Maria, recognizing that disability impacts 1/4 of people in their lifetime, right? So making the healthcare system on the adult and pediatric side can be incredibly impactful. And I'll say a few words about our new initiative, and if people are interested, we can say more. But really now, so these are the different elements that we have added to our transition clinic visit, really trying to bridge the gap between, the pediatric and adult sides. And for and so we're trying to add a new both study, how people are using Medicaid and how Medicaid use is impacting access to care, but also looking at an insurance enrollment intervention, partnering with Covering Wisconsin to provide people with insurance navigation in addition to some of these other tools, with the goal of having fewer people be lost in the transition from pediatric to adult care. And really what we're hoping to contribute to is a community-driven, accessible, and scalable care model designed by people like Maria, who want to improve value-based care and statewide health interventions. And many of you on this call may be aware that Children's of Wisconsin and UW Health Kids are joining together to care for all children across the state of Wisconsin in the Forward Pediatric Alliance who have congenital heart disease. And this is really, this, pilot work has, or this formative research is preparing us for a pilot in both of the congenital heart disease clinics across the state. And really the idea is that by using data from across the state, we can address the barriers and facilitators to investment in healthcare that bridges the gap in transition, and makes healthcare more accessible to all people with disabilities. Our team is really hoping to transform survivorship for people like Maria. And our goal is to create a more accessible healthcare system, first for people with congenital heart disease, and then for everyone in our region, really by centering people with disabilities. Today, there are several members of our team here. It takes a huge group, like I mentioned, to do work like this. And we're happy to talk with you about our experience. And if you have feedback that you'd like to share, you can scan that QR code, and it helps us learn what information people are interested in.
Well, thank you so much, Dr. Olson. You all have been really, really busy. I love the partnership that you have going on. The looking at what's working and let's adapt it and get it to work better is fantastic. We would love to open it up to questions, or even if there are members of Dr. Olson's team that would like to maybe high point something else that they would like to talk about. But please put your questions in your chat, or feel free to raise your hand, and we will call on you. I'd like to start with just, can you tell me a little bit more about the partnership you have going with Children's Wisconsin, and are you're researching the same thing, implementing the same tools together, and just trying to get a more diverse sampling of people?
Not yet. I think our first goal really is to look at what each program is doing. Transition actually happens quite differently at the two centers. Um, and so that I think is a point of interest. And I think important for all of us to understand is that patients are shared between the two centers. um, Many of the patients that are cared for in Madison had some of their initial repairs, at Children's of Wisconsin. Also people move around the state or have been cared for at both of the centers, in many cases. But I think really our first steps are to learn how each center is approaching transition, and then try to understand, what that looks like at each center. And I think that's very representative of what happens nationally in terms of the different kinds of ways in which patients are transitioned, whether they're cared for at a pediatric hospital into adulthood, or transition to an adult hospital at a particular juncture in time.
We do have a question in the chat. One of our people have asked, what kind of support have non-medical providers been able to give that's proven helpful to youth in transition? Is you have a pretty robust model of including families and community support. What are non-medical providers being able to help out in?
They're doing a lot. Um, I mean, obviously families do a ton, and have a very specific understanding of what the needs of that young person may be and what their support needs may be. And a lot of we see in clinic that a lot of what they do is kind of built into their everyday interactions with, the young people that they support. So whether that's, you know, having, families described all different kinds of hacks and tips, including like knowing which, kind of alcohol rub thing was gonna get the adhesive best off of, after having the monitoring stickers, working with young people to prepare them for visits. Many families described very in-depth, kind of, routines, to prepare their young people to come to clinic visits, that were quite lengthy, sometimes taking up to weeks at a time. Um I think, some of the other areas that we've found, oh, you're asking, so most of the support is family support, not provider support. So I think some of the other supports that we see being very, we're hoping can impact care. I think the resources for students with individualized education plans are currently underutilized, in terms of, and we've started supporting our patients by making recommendations around having healthcare transition goals as part of someone's, or health advocacy goals as part of someone's individualized education plan. We see, some examples of patients for whom there's very robust involvement of the school and perhaps the school nurse, or counselor, in supporting those young people. But it's very variable across the state, I would say. Um, I think huge opportunity. We partnered with the department, as you saw, the Department of Vocational Rehabilitation. I think huge opportunity to earlier identify those young people who could benefit from, job development and training, and partner with schools to support those young people as they age. As I alluded to when I was talking about the silos, I think better integration across domains of transition is really critical. But I think the most important thing to hear is the tracking, right? Because if you're a person who has, acquired disability over time and it's not recognized either by the school or by the healthcare system or by the other supports and services in the community, and you get to be, 18 or 20 or 23, it becomes quite difficult to access those services in the amount of time that that can be impactful for a young person before they end up in a situation where they're um, employed in a less than stable setting, maybe not having access to private insurance that they would need to support their extensive healthcare expenses. And then they're really struggling. And that's really when we see people drop out of care. And I would say almost no one is aware or connected to those insurance navigation resources that are available. And so, um, and I think education around, I think we have been doing education through the transition readiness assessment around, education and awareness related to insurance. But I thought that many of our participants said it best, the family members said it best, where they said, like, if this is something I've been trying to navigate for 20 years and I still don't understand, like, how do we think that this, medically complex young person is suddenly going to be able to navigate this, incredibly uh, difficult, complicated, bureaucratic quagmire independently, you know, because they turned 26. Um, so um, Lynn said, we know from talking to various clinics and systems in Wisconsin that the buy-in support from health system leadership for investing time in transition is key barrier. How do we build this buy-in? I don't know, Brianna, are you still on? Would you like to answer that? I don't know if you're able to unmute.
I'm here. Hello, everyone. So they're wondering, this is from Lynn.
Yeah. How did we build buy-in?
Honestly, I think just continuing to have a presence is going to be the best option. It's challenging. I do think that it's becoming more of a buzzword in pediatrics. When I first started the transition clinic in the peds cardiac clinic, we had lots of resistance, and the people definitely felt threatened or like as if I was going to steal their patients. And then once they actually had a better understanding of what our healthcare transition clinic was, and it was just lots of education and trying to improve the patient's confidence and knowledge about healthcare and their own health, then now everybody's like, oh yeah, they definitely need this. They definitely need this. So I think continuing to just share education and the positive experiences, but and there's like now we're getting compensation potentially with the CPT code. So that's helps as well from leadership like management perspective.
Yeah, that was
I mean,
going to be my follow-up question. Sorry, was just, do you feel like you're getting payment for your time and services? Because that's definitely what we're hearing from others is leadership won't let us do the work because we won't get reimbursed for this time. Sorry, Krisjon.
Yeah, I mean, so there's a CPT code, which is helpful, and every insurance is different. So we don't have, I don't feel, maybe Mark or Tim knows, he might know this actually. If there is specific data of insurance reimbursing it or what the percentage is, but I know of other peds clinics that are using it. And then what we find is, or other clinics at UW, is if the physician is putting transition of education and using that CPT code, then that is helpful. So it's becoming more of a thing, but slowly.
Yeah, the other thing that I was going to mention, just from the pilot work that we've done with the adapted transition readiness assessment very recently, and this is, really limited data. It was just 16 patient encounters. But in that process, one of the waves that we undertook, we did provider coaching to improve provider comfort with initiating, transition education topics. And I think one of the interesting things that happened is often when we would be screening patients for participation, and if you would bring up to a provider, well, can we try to do transition education for this group of patients this week? They would say like, no, my clinic's so busy, I'm not gonna have time. And then when I would do the provider coaching session, they were like, well, definitely we can, talk about how, they have this kind of complex, neurodevelopmental diagnosis and don't have an IEP yet. That's critical, for their care going forward. And so when you got into the specifics for an individual patient, there's a lot of buy-in from providers once they saw the overall relevance to the specific patient. But I think sometimes when you're talking more generally, the response is, there's an ever narrowing clinic template and ever expanding needs for what can happen in that short amount of time. So one of the things that we're trying to better understand going forward is which components are best delivered by which members of the team. Are there some components of education that are best delivered by providers? Are there some components of education best delivered by nurses? What is the role for medical assistants and schedulers? And so on and so forth. And with the hope that if everyone on the team is doing, some part of the work, that it becomes less for everyone overall.
Well, I know I look forward to learning about how that works out, because I know there are plenty of places that are asking those exact questions. And so we're looking forward to learning more about that. Other questions, comments?
I can always keep asking questions because I have a lot of them, but I want to give space to others. But I'm wondering if others might be interested, or if you have the ability to show us your transition readiness assessment.
Oh, the adapted one?
And maybe that's, intellectual property and, and that can't happen.
I don't think so. I don't know. I don't have it pulled up on my slides. We don't have like a pretty version of it. Like for in a single slide. I don't know, Hamail or Michaela, do you want to describe what it looks like? Or maybe someone can, I don't know if someone has the iPad there, if they can show it.
I can just give a description of what it looks like. It starts by asking who's filling out the survey, because we know sometimes young people fill out themselves and sometimes they need a support person to help them. So it's designed that they can do as much of it as possible themselves with whoever's in clinic with them to support them. And then it goes through just a lot of daily activities, and certain things are important for managing their health, like getting to clinic, taking their medications, seeing a counselor, and what level of support they need to complete each one of those tasks on a scale of 1 to 5. And then at the end of the survey, it calculates those numbers to see what areas that they need the most support in. And then a provider receives those results and can address those areas that they need the most support in.
Yeah, in addition to that, we usually administer this on an iPad. And so that's very helpful for patients and families to be able to navigate the survey. So they're able to zoom in, they're able to zoom out, they're able to attach a keyboard. So usually we have an attached keyboard so that if they find that typing is a little bit faster, which is definitely something that we've seen for a lot of participants as well. And then towards the end, there's also a portion for providers to give their input as to where they feel the patient falls in certain categories as well.
Yeah, so the domains where support was needed, I think that young people and their families, everyone felt like the gut transition domains were relevant, but I think it was really around the scale where we were able to make changes to start to see, could we measure how much support they need to complete these tasks? And Brianna, thank you for putting the link to the survey in the chat. That way you guys can just check it out. Another shift that we made, again, I think we know that young people come into, and adults come into clinic with other people. And so that's one of the things that we also shifted to see who do people identify as supporting them. To the earlier question about who are the people that support this young person. And so you can see based on the feedback from patients and families, we included a wide range of individuals that may include coaches, counselors, teachers, and so on and so forth. So we're starting to get some idea about what the range of people providing that support looks like. And then another piece is that young people felt it was very important that they be able to prioritize what aspects of transition education they would want to work on. And so now we have a ranking system where they rank what they would most want to work on for their next visit. And that was a shift from the original transition readiness assessment. And then the graphics and plain language. And as Hamal was saying, I think one thing that we've definitely made note of is, and I think that we're continuing to explore the extent to which we can maximize the accessibility features of the iPad to make the survey most accessible. But in this pilot research, we've had participants with low vision and different kinds of communication needs, and seen a real benefit in activating the accessibility features on the iPad. And then, of course, for people that have those kinds of needs, they're also often very adept at being able to maximize and alter that technology to best fit their needs. And we've actually seen them in clinic. You know, they know how to go into the settings and shift it so that it's appropriately sized, you know, so that they're able to, for example, for our participants with low vision, so that they're able to visualize the questions without assistance. So what we've seen in the pre-pilot is that young people were much more able to complete the transition readiness assessment without additional support because of the changes that we had made. But it is sometimes time consuming. So that's the eternal battle.
Yeah, thank you for that really thorough description. It's really amazing work. And especially the focus on, you know, building out those natural supports, you know, learning about those and building those out. I think that's a key element that we haven't seen a lot of other clinics or systems talking about.
I also greatly appreciate the question about what is it you want to work on, because I know as a parent, I have great ideas about what I think my kids should be working on and should be doing, but they're probably going to work on the ones they find important rather than the ones that I find important. And so I think that's a really great question to ask them as well.
Yeah, and actually, I can go back to the question prompt list. I think when we were working with young people on the question prompt list, um, I learned a lot. I mean, I think just in what questions they have, right? I think the one that was most surprising to me that they really want, I don't know if you can see that I zoomed in, but they really wanted to include, how do I plan for my future health needs? What if I don't transition? They thought this was a key. They want to know, like, if I don't make this transition to the adult clinic, what will happen? Which, and I think the other thing that was really surprising to me, they really had these questions about what is daily life going to look like as I get older. And they were not interested in the 3 months. They wanted to hear from the provider about, 10 years from now, what is this going to look like to me? And that wasn't a time frame that I had anticipated, and it was really important to them. And I think, when you think about the healthcare uncertainty, all of these questions are related to that uncertainty that they experience, which, it's kind of beyond the scope of this presentation, but I think really contributes to the mental health concerns for this population, which are profound.
And then in the chat, I think that there's a question just about, depending on what you choose, do the questions change on the survey? Or is it the same survey whether you choose pediatric or adult clinic?
Zhao, do you want to expand a little
I
bit?
can talk about this. So actually, there are like 3 branching logics. Among like a pediatric clinic, if you are 12 to 16, you get like 1 set of questions. There are actually like fewer questions for this age group. And if you are like older than 16, then you get like another set of questions with more questions. And then if you choose adult clinic, so I remember like, in pediatric clinic, there are questions about like, whether you plan to transition, within the next year or something like that. So for adult, because they already transitioned, so there's no question. So only slight difference between the adult clinic and the older, kids from the pediatric clinic.
Thank you.
Yeah.
Any last questions or comments before we close out today's learning community? This has been really fantastic.
I guess just for the folks on this call, I think one of the interesting findings from some of the pilot work that we've been doing is that we haven't seen a significant difference in the support needs of patients based on age. And so I think that's something that's very important to keep in mind as we think about transition, and what people's support needs may be. It may in fact not be related to age. And so, we're going to do more work to try to understand, is there a relationship that we can find between what someone's support needs? Is it related to diagnosis? Is it related to, environmental factors or other things? But I think, obviously very preliminary, and we need to do a lot more to understand it better. But we aren't seeing a huge difference in the support needs of, say, a 23-year-old versus, someone who's younger.
Well, we look forward to having you back in a year or so to update us on what is happening and what more you have learned. We really appreciate it and appreciate the work that you are doing with fellow providers, as we say at the Weisman Center, at those places across the street. So we know that there are plenty of people that are interested and are looking for help in how to do transition better for their clinics. So thank you for doing the research to give us some of those answers. We're going to go ahead and launch our poll question to help us improve. So I hope that you have the opportunity to
friends and community, for sure.
Yeah, we're really interested in hearing from Special Olympics on September 25th for our last learning community. That also answers the question, Krisjon, about did I recognize somebody in one of those pictures? And the answer is yes. Yes, I did, because I know him from his work in Special Olympics. So that's fantastic that you're partnering with them as well. We're going to be joined by Cassie Hopp, the Director of Inclusive Health at Special Olympics Wisconsin. For more information, register. Please see the link on your screen. We'll also add it into the chat. We also want to remind you that if you go to our website, you're going to find information on the healthcare transition IDD Echo that's coming that we have ongoing. The next Echo session will be May 13th, and we'll be learning about mental health barriers and options during the transition to adult services. Link to learn more is in the chat. And you are always free to join our ongoing Transition Talks Tuesday series, which we have 2 left in this upcoming series. We'll be joining in May. We're going to be learning about how to connect with Department of Vocational Rehabilitation and what does DVR have to do with transition. And so we hope you could join us for that. And then we do send out a regular bi-monthly newsletter type called Transition Transmission, which it's not a newsletter. It's an email full of stuff that come across my desk that I think other people might be interested in. So feel free, you'll find more information on that on our website as well. Thank you feel free to take the poll. Did you learn at least one new resource or strategy? If I was able to take the poll, then I would say yes, definitely yes, would be me there. So if you want to add one more for that. So thank you so much. And again, Dr. Krisjon Olson and team, thank you so much for being with us today, for the work that you're doing to promote and further transition. This is light years ahead of where we were 5 years ago. You guys are doing great work. Thank you so much for being here.
Thank you for inviting us.